Yeah, so this is basically a study from China. So we know EGFR receptors have significant therapeutic effect in the treatment of advanced non-small cell lung cancer with EGFR mutations, but acquired resistance greatly limits the survivor benefit of these drugs for EGFR mutant patients. So this study aimed to assess the efficacy and safety of SBRT plus EGFR TKIs in these patients. This was a prospective randomized controlled phase 2 study from 4 different hospitals in famous or rather infamous Wuhan, China. Eligible patients are histologically confirmed to have lung cancer with EGFR sensitive mutation, either exon 19 deletion or 21 L858R, and diagnosed with stage 4. And the number of metastatic sites should be less than 5. So all these patients received first generation TKIs like gefitinib and rotenib, and at the end of 3 months they had an imaging. Those patients with stable disease or partial response were included in the study. So they were randomized into 2 arms, 1:1 fashion. One arm received TKI alone, and the other arm received SBRT. So SBRT was started soon after the completion of 3 months, and it was supposed to be finished in 4 months. So SBRT was given to different sites, like either the primary or to the metastatic sites, and it was at the physician's discretion. So this part is not very clear how they chose the patients for the radiation to primary or to the metastatic sites. And the dosage was 30 to 50 gray as 5 fractions. The primary endpoint was BFS and the secondary endpoint was OS. And between May 4th, 2018 to 2019, 74 patients were screened and 62 patients were found to be eligible and enrolled and randomized. The study was closed early with due to slow accrual, like only 62 patients could be recruited. Probably COVID also had an impact. And the enrolled patients were randomly assigned to receive either SBRT plus TKI or TKI alone, 31 patients in each arm. And 61 patients were finally included for the analysis. So at the end of median follow-up of 29 months, so the median PFS and OS was found to be significantly better in the combination now. The median PFS is 17.6 versus 9 months, with the hazard ratio is 0.52 and a significant p-value. And overall survival was also higher in the combination now, that is 33.6 months versus 23.2 months. So if we see the graphs, we can see the curves are clearly separated, and the C, it's not very visible, C and D shows the effect of radiation to the either primary or the metastatic site of the survey. So we can see the patients who received SBRT to the primary tumor had a better median PFS compared to the other groups. Like they had a median PFS 27 months, but the median PFS was 10 months for the patients who received SBRT to the metastatic site. And few patients who received SBRT to both sides, they had a PFS in between the two, like 17.6 months, and here also the p-value was significant. So this was reflected in the overall survival also, though it was not significant. The patients who received SBRT to the primary tumor had an OS of 49 months, where it was 24 months for the patients who received SBRT to a metastatic site, and it was 28 months for patients who received SBRT to both sides. So, and the toxicity, there was no grade 3 toxicity in either arm. Grade 2 toxicity was slightly higher on the combination of 50% versus 45%. And also there was no difference in the emergence of T790M mutation rates. And as I've already mentioned, the outcomes were better for those patients who received RT to the primary. So they concluded as the additional SBRT significantly delayed the onset of acquired resistance to EGFR TKIs and prolonged the PFS and OS of patients. Radiotherapy is the primary lesion alone might be superior to the metastatic size, and further confirmatory studies are needed to confirm our finding. So this is definitely an interesting study, but this study used the first generation TKIs. It did not know the impact of using osimertinib or TKI plus chemo in these patients. And obviously it's a small phase 2 study, and the arms were not equal, like the slightly higher number of patients with visceral metastasis on the TKI arm. And they've taken only patients who had response to TKI. So already there is a filtering of better subgroup of patients. And another important thing is, how did they choose the patients for primary versus metastatic for SBRT is not clear. That is just mentioned as decisions discretion. So that basis is not clear. So definitely this is an interesting study, it's a promising study, but we need more larger studies. And in our practice, especially as a majority of patients do not have access to osimertinib, it may be explored in a subgroup of patients after a proper MD discussion, especially those with oligometastatic disease. And those patients may benefit from addition of SBRT to TK, but definitely we need more studies. Thank you.